Hello everyone, welcome to this interactive video series designed to help you become comfortable with reading chest CT scans. In this video, we will cover basic anatomy and an approach to reading CT scans of the chest. To follow along this video, you can use your phone camera to scan the QR code on the screen and scroll through the case on your phone. If you are on a computer, you can click the link in the description below to open the case in a separate browser alongside the video. The case will contain different series that you can access on the left side. If you're using your phone, there will be an icon in the top left corner to access the various series. If you want to support our channel, please like and subscribe. We share interesting cases and are developing detailed radiology courses that are easy to understand and follow along. Part 1. Understanding contrast timing. Now let's focus on CT scan of the chest. There are various ways to image the chest with CT, and each has its own protocol. For this particular case, a routine protocol with IV contrast was used. However, it's important to note that you can also have a non-contrast CT chest without IV contrast. When IV contrast is administered, the timing of the scan after injection affects the appearance of the images. If we image the chest very early, approximately 15 seconds after injection, the pulmonary arteries will be filled with contrast and appear very bright. This protocol is called CT pulmonary angiogram and is used to diagnose pulmonary emboli. Intermediate imaging. If we wait a little longer, about 20 seconds after injection, the contrast will move from the pulmonary arteries into the lungs, back to the pulmonary vein in the left heart, and then into the aorta. In this case, the aorta and other arteries will appear very bright. This protocol is called CT angiogram of the chest and is used to assess the arterial vasculature, such as ruling out an aortic dissection. Late imaging. If we wait even longer, around 60 to 70 seconds after injection, the contrast will distribute further, resulting in optimal enhancement of soft tissues. This is the routine contrast enhanced CT of the chest, commonly performed for comprehensive assessment. And that is the contrast enhanced CT that we will be going over today. Starting with the anatomy. Now let's explore the anatomy in detail as we scroll through the axial images of the chest. The thoracic cavity is the central focus, surrounded by the chest wall, which includes the bones and the muscle encasing the cavity. The thoracic cavity extends from the thoracic inlet, which is the top opening bounded by the first ribs and the manubrium sterni, all the way down to the thoracic outlet closed by the diaphragm and bordered by the inferior aspect of the rib cage and the bottom of the sternum. Mediastinum. Within the thoracic cavity, we have right and left lung, and this is the thoracic cage. Located between the right and the left lung, there is mediastinum. The mediastinum is divided into compartments, and it is crucial to understand them because different pathological processes occur in each compartment. To understand the division of the mediastinum, we will use the fibrous pericardium as a landmark. We can see that better here on the SAG images. So fibrous pericardium is a sac that surrounds the heart with the fibrous component being the outermost layer visible on the CT scan right there. It inserts into the diaphragm inferiorly and extends to the level of the root of the great vessels superiorly. Above the pericardium and below the thoracic inlet is the superior mediastinum. So right where the upper margin of the fibrous pericardium ends at the base of the major vessels, and above that level up to the thoracic inlet right here, that segment of mediastinum is called superior mediastinum. It contains structures such as trachea, which is this air-filled structure, esophagus, which is posteriorly that is collapsed, and contains other vascular structure, which we will discuss later. Anterior to the pericardium is the anterior mediastinum. Usually it's an empty space. So this is the anterior mediastinum that does not usually contain structures in adult patients and predominantly is occupied by fatty tissue. However, in young patients, it can house the thymus gland, lymph nodes, and sometimes the thyroid gland if the thyroid is enlarged and is extending inferiorly from up here into the anterior mediastinum. Other etiologies that can occupy the anterior mediastinum are: when evaluating an anterior mediastinal mass, the classic differential diagnosis includes thymic lesions like thymoma, thyroid lesions, lymphoma, teratoma, and other germ cell tumors. Within the pericardium itself lies the middle mediastinum, which consists mostly of the heart and the vessels connected to it. This includes the ascending aorta, pulmonary trunk right there, superior vena cava right there, the tracheal bifurcation. This is the trachea and that bifurcates right there. And some lymph nodes may be present in this space as well. Moving posteriorly, posterior to the pericardium, we enter the posterior mediastinum. This region consists of structures such as the spine, the paraspinal nerves, and the esophagus right here. That's the esophagus. It is collapsed right there. When dealing with posterior mediastinal mass, neurogenic tumors are the most common differential diagnosis. Now let's focus on the heart and the anatomy of the heart. The heart sits within the mediastinum, and understanding its anatomy is crucial when interpreting a chest CT scan. We'll cover some key structures of the heart visible on a CT scan. Starting with the right side of the heart, we have this superiorly right here, that's the right atrium, where major systemic veins, namely the inferior vena cava and the superior vena cava right here, drain into. The right atrium is also comprised of the right atrial appendage and the crista terminalis, so this soft tissue thickening right there, coursing along, is crista terminalis. Crista terminalis is the muscular ridge running from the superior vena cava from right here. That filling defect kind of soft tissue thickening goes up to the level of IVC right here. Adjacent to the right atrium is the right ventricle, which receives the blood from the right atrium and pumps it up into the pulmonary trunk. Right ventricle is defined by the moderator band. This is a muscular band that originates from the interventricular septum right there and inserts into the right ventricular wall at the margin. It is important to note that the right ventricle is typically thinner as compared to the left ventricle and contains a moderator band. From the pulmonary artery, the blood flows into the lungs and then it returns via the pulmonary veins right here into the left atrium. And from left atrium, the blood goes into the left ventricle and then it is pumped up here superiorly into the aorta, and from the aorta, it goes to the rest of the body. In the left atrium here, important structure to identify is the left atrial appendage, which is right here. And this atrial appendage can have thrombus, and also sometimes there is mixing artifact from the contrast. So artifactually, there might be some filling defect kind of appearance that may be misperceived as a thrombus. The left atrium is less than 4 centimeter in AP dimension. If it is more than 4 centimeters, it be considered as dilated, and good rule of thumb can be if it is more than 5 centimeters, it is definitely dilated. Left ventricle here is relatively thick muscle wall and has this prominent muscular filling defects within it. These are papillary muscles. Vascular anatomy. Starting the vascular anatomy, the aorta arises here and the ascending aorta arches over and gives off major branches. The first major branch that the aorta gives is the right brachiocephalic trunk, which is right here. And this right brachiocephalic trunk goes on further and divides it into right common carotid artery, which goes up here, and the right subclavian artery, which courses laterally into the right upper extremity. The second branch of the arch of aorta is the common carotid artery, which is right here, the common carotid trunk. And then the third major branch is the left subclavian branch, which is the third major branch and which courses laterally into the left upper extremity. The descending aorta progresses into the abdominal cavity. The aorta gives rise to the coronary trunks. So the left main coronary artery originates from the left coronary cusp right here. It divides into the left anterior descending artery, which courses anteriorly along the interventricular septum. The lateral branch of the left main coronary artery, the left circumflex artery, courses in the interatrioventricular groove laterally and along the posterior margin. And then the right coronary artery arises conventionally from the right coronary cusp right here, and the right coronary artery courses along the right and atrioventricular groove posteriorly. Going to the venous anatomy, superior vena cava drains into the right atrium, and it is formed by merger of right and left brachiocephalic veins. Right brachiocephalic vein is formed right here by the fusion of the left internal jugular vein, and then laterally it is joined by the right subclavian vein, and they form the right brachiocephalic vein. The left brachiocephalic vein is longer in course right here. It is opacified with contrast on this particular exam, and left brachiocephalic vein is formed by the fusion of left subclavian vein and left internal jugular vein, and these both veins combined form the left superior vena cava, which drains into the right atrium. Inferiorly, IVC, which is the largest vein in the body, drains into the inferior margin of the right atrium right here. Another important venous structure is coronary vein, also known as the largest cardiac vein, which runs along the posterior aspect of the heart right here and drains into the right atrium. This is the coronary vein. Another important venous structure is the esophagus vein. Esophagus vein joins into the superior vena cava above the right main bronchus. So this is the right main bronchus, and there's a vessel that courses right above that from posteriorly. That's the esophagus vein that joins into the superior vena cava. Moving on to the anatomy of the airways. The lung window shows the airway anatomy much better, because if there are any mucosal secretions, that also can be seen on the lung window. The trachea goes down here and bifurcates into the right mainstem and left mainstem bronchus at the level of carina. And on the coronal view, there is this is the right main bronchus and the left main bronchus here. As you may notice, the left main bronchus is longer and more angulated laterally, while the right main bronchus is smaller compared to the left one and is more steep in angulation, predisposing the right mainstem bronchus to aspiration. So the length and the angulation of the right main bronchus favors the aspirated contents to go into the right main bronchus and then down into the right lower lobe. Moving to the posterior mediastinum, we encounter esophagus right here. Tiny focus of air that is present is within the esophageal lumen, and it's usually a collapsed structure. It extends from the thoracic inlet down all the way into the stomach. Then this is the GE junction. Now let's shift our focus to the clinically important lymph nodes stations. We'll cover key nodes that you need to be aware, starting with the supraclavicular region. So we identify the clavicles, and in the lower neck, in the supraclavicular region, we need to look for the supraclavicular lymph nodes. Next, we have prevascular lymph nodes, the lymph nodes in the anterior mediastinum, anterior to the major vessels. That's the location for prevascular lymph nodes. Moving downward, we encounter the aortopulmonary lymph nodes. So this is the arch of aorta, and this is the pulmonary trunk, and lymph node between these two structures, which is this area, is called the AP window, and that's where we look for the aortopulmonary lymph nodes. Paratracheal lymph nodes, as the name suggests, are around the trachea. So this is the trachea, and paratracheal lymph nodes can be left paratracheal or right paratracheal lymph nodes. Going down here, right at the bifurcation of the trachea, at the level of carina, inferior to the carina, this is the subcarinal lymph node area. Laterally, there is this right hilar region or right hilar lymph node, and on the left side here, that's the left hilar region. We look for left hilar lymph node there. Posteriorly, along the esophagus, there may be paraesophageal lymph nodes that we need to look for. Anteriorly and inferiorly below the heart border, this is the area where the cardiophrenic lymph nodes are present if enlarged. This is the area for the left axillary lymph node. As we can see, there are these tiny sub-centimeter lymph nodes with normal morphology. Here on the right side, tiny sub-centimeter lymph nodes with normal morphology, not enlarged. Typically, the size of the lymph node to be considered enlarged is greater than 10 millimeters in short axis. There's one exception, the internal mammary lymph nodes. This is the right internal mammary artery. This is the left internal mammary artery, and they travel along the inner chest wall on each side of the sternum. And lymph nodes along these vessels are called internal thoracic or internal mammary lymph nodes. These lymph nodes are usually not visible, and if they are visible, they are considered enlarged. A good cutoff is 4 millimeters and above. Now we will go over the anatomy of the lung parenchyma. To understand the anatomy better, we need to identify the fissures that are dividing the various lobes of the lung parenchyma. On the right side, there is this oblique fissures. This thin line that is coursing inferiorly is the oblique fissure. And then there's another minor fissure, which is a thin line anteriorly that divides the upper and middle lobe anteriorly. And oblique fissure divides the inferior lobe from the upper and middle lobe. This can be better seen on a coronal image. So here we see this is the oblique fissure that's coming down here, and then it goes all the way down, and then this is minor fissure that extends lung parenchyma above the minor fissure, and anterior to the oblique fissure is the upper lobe. The lung parenchyma inferior to the minor fissure and anterior to the oblique fissure is the middle lobe, and the lung parenchyma inferior to the oblique fissure is the right lower lobe. On the left side, it's less complicated. There's this one single oblique fissure that divides the left upper lobe and left lower lobe. Inferior part of the left upper lobe is also called lingula. So once we've identified these fissures, we'll go over the anatomy of the segments of the lung parenchyma. Right lung parenchyma is divided into 10 segments, and the left lung parenchyma is divided into 8 segments. So we will track each single segment by tracing the airways. The trachea goes down here. It divides into the right main bronchus and left main bronchus. We follow the main bronchus. So the upper lobe bronchus is this one right here, and it gives rise to 3 branches. So the one is that goes anteriorly is called the anterior segmental branch. The one that goes posteriorly is the posterior segmental branch right here, and this one goes superiorly. It's called the apical segmental branch. Our right upper lobe is divided into apical, anterior, and posterior lobe. Moving down, bronchus intermedius gives rise to the right middle lobe bronchus and right lower lobe bronchus. Right middle lobe bronchus goes anteriorly and divides into medial and lateral segments, making 2 segments out of the right middle lobe. So this is the medial lobe branch, and this is the lateral lobe branch. And then we follow the right lower lobe bronchus. that goes and divides into 5 branches. It divides into superior branch, which is extending superiorly, which is this branch here. This is the superior segmental branch of the right lower lobe, and the branches inferiorly are divided into 4. So the one which goes anteriorly is called anterior segmental branch, that goes laterally is called lateral segmental branch, a branch that goes medially is called the medial segmental branch, and the one that goes posteriorly right here becomes the posterior segmental branch. So making 5 segments out of the right lower lobe. Moving on to the left lung parenchyma. So the left main bronchus divides into the lower lobe and upper lobe bronchi. So this is the left lower lobe bronchus supplying the left lower lobe, and this is the left upper lobe bronchus. So the left upper lobe is divided into 2 segments, anterior and apico-posterior segments. The first branch that takes off anteriorly, this goes to the anterior segment of the lung parenchyma, and then the branch that goes posteriorly and superiorly is called the apico-posterior segmental branch. Now we'll follow the lingular branch that had taken off before, and the lingular branch goes down here, and it divides into superior segmental and inferior segmental branches. This is the lingular branch that goes up here, and it gives off this branch. This is called the superior segmental branch, and this is called the inferior lingular segmental branch. Going to the left lower lobe airway anatomy, it gives off an apical segmental branch, which is the superior most branch, which takes off this branch right there, supply the superior segment of the left lower lobe, and there are 3 other branches: anteromedial, lateral, and posterior segmental branches. As we can see right here, it divides into, this is the anteromedial branch, this is the lateral branch, and this is the posterior segmental branch of the left lower lobe, making 8 segments in the left lung parenchyma. Now we will discuss the anatomy of the pleura. So pleura is a thin line that separates the lung from the chest wall. The line that coats the lung parenchyma is visceral pleura, and the lining that coats the chest wall interiorly is called parietal pleura. The pleura is routinely not visible unless it is thickened due to some pathology, or there is some fluid or mass within the pleural space, that is, space between the parietal and the visceral pleura. So pleural effusion will be a fluid collection right here between the pleural lining, and otherwise in normal cases we don't really appreciate pleura on imaging, but it is important to understand the anatomy to be able to localize the disease process. Moving on to the chest wall anatomy. The chest wall contains of the subcutaneous tissue right here. In this particular patient, there is this Mediport catheter that is present in the left chest wall that courses above the clavicle and goes into the left brachiocephalic vein down into the superior vena cava. The other thing to look for in the chest wall is the bones. It starts from superiorly, we see the right clavicle. This is the left clavicle. These are the humeral heads that we see. Going inferiorly, this is the right scapula, this is the left scapula, and these are multiple ribs that are on both sides going all the way down. Sagittal images are usually very helpful in understanding the bones, especially the spine, and if there is any compression fracture deformity, we will be able to appreciate it better on the sagittal view. And in this particular patient, the vertebral bodies are maintained in height and alignment. There is no compression fracture deformity, and sagittal view also shows the sternum anteriorly really very well, and we evaluate sternum. Sometimes lateral rib fractures are difficult to evaluate on actual images, so the SAG images are usually helpful, and we are able to see the rib fractures sometimes better on the SAG images. Now we will be discussing approach of reading a chest CT scan. So first thing to look for is the scout image, because scout image sometimes includes the structures that are not part of the entire CT scan. So the edges of the exam, like sometimes a lower neck is included more than usual, or abdomen is included on the scout images, and there might be finding that may be pertinent for that particular patient. So scout images are the place to start with. Then going on to the axial images of the CT, we start with soft tissue window and start from the top of the scan. Here we see both the clavicles and the humeral heads. First, look at the thyroid gland up here. The thyroid gland is radiodense structure because of iodine in it, and we look for any thyroid nodules. If we do identify any thyroid nodules, we recommend follow up based on the ACR guidelines depending on the size. And going down here, we look at the supraclavicular lymph nodes. It's important to understand that there are multiple lower neck muscles that can appear like a lymph node. So we should be able to track these muscles really well and make sure that we are not looking at a muscle thinking that as a lymph node. So that's important to consider. The other thing that we look from on the soft tissue images is the entire soft tissue around the chest wall, and we can see there are these pectoral muscles on both sides going down. This is the right axillary region, left axillary region. We look at these lymph nodes and look at the size and morphology. In terms of measurement, we try to measure the lymph nodes in short axis. Then we look at the breast parenchyma. In this particular patient, there is some nodularity in the lateral breast with surgical staples related to a biopsy of the breast mass. Going down here, we look at the soft tissues further down. Then we focus our attention to the mediastinum. In the mediastinum, we look at the soft tissues first. We look at the area where there might be enlarged lymph nodes, both paratracheal areas, AP window, going down into the prevascular space, subcarinal region right here below the carina, and then bilateral hilar region. One important thing to remember is right hilar lymph node up to 9 to 10 millimeters is normal, but if the left hilar lymph node is enlarged and measures up to 10 millimeters, that is abnormal. So that's something to keep in mind. Going down to the vessels here, the major vessels, we look for the main pulmonary trunk, and when it is very well opacified, we look for any filling defect in the branches of the right pulmonary artery. Right here there is and its branches. Then we trace down the left pulmonary artery, superior branches, inferior branches, make sure there are no pulmonary emboli. We look at the aorta and look at the size of the ascending aorta and make sure it is not dilated. The usual cutoff is dependent on the institutions, but we tend to take a cutoff of 4 centimeters as the upper limit of normal for the ascending aorta and 3 centimeter as the upper limit of normal for the pulmonary trunk. Then we look at the coronary arteries and look for any obvious big calcification that might be there. Subsequently, we go down and look for the heart and see cardiac anatomy is normal. Look for the size of the each chamber. A good cutoff for the left atrial enlargement is 5 centimeters AP dimension. We look at the left atrial appendage that may have a thrombus. We pay attention to the left atrial appendage and make sure that we are not looking at a mixing artifact. In this particular case, there is this mixing artifact that's grayish area, and that is normal. We look for any pericardial thickening, any pericardial effusion. We look for pericardiophrenic lymph node that may be enlarged. After all the mediastinal structures, we focus our attention to looking at the lungs. A MIP image is a good, thick, sliced image of the chest CT, and you can see vessels really well. And vessels will be like these long structures, and lung nodules are easy to identify on the MIP images, and it gives us a good overview of the lung parenchyma. And once we have identified the lung nodule on the MIP images, we go back and look at the same nodule on the axial lung window images and try to characterize it further. After characterizing any opacity or lung nodules, we look for pleural effusion and any pleural abnormality. Soft tissue windows are good for that. And we see if there's any pleural thickening or any pleural fluid. We look for any free air that is better seen on lung windows. And moving down, part of the upper abdomen is included on the CT of the chest routinely. We look for the structures that are visible to us, like sometimes right adrenal gland is visible, left adrenal gland, upper part of the kidneys. Look at the liver, the pancreas, the spleen, the visualize loops of bowel, and see if there's any abnormality there. And this is it. This was a quick overview of the anatomy of the chest and approach to reading a regular normal chest CT. If you found this content useful, please like and subscribe to our channel for weekly content ahead. Thank you.